Good day. I'm Professor Jennifer Olusegun from Obafemi Awolowo University, Ile-Ife, Osun State, Nigeria. I'm presenting cervical cancer, presentation and management. The learning objectives of this lecture: you must know the global incidence of cervical cancer, the pathways toward the development of cervical cancer, the symptoms of cervical cancer, the clinical staging of cervical cancer, the investigations needed to be done when managing patients with cervical cancer, the modalities of management of different stages of cervical cancer. Cervical cancer is the leading gynecological cancer in many developing countries. It's the fourth leading cause of cancer death globally and the second most common cancer in females. The burden of cervical cancer is on the increase in many developing countries. It is a major reproductive health problem because it affects pre- and postmenopausal women with resultant social and economic implications for the affected communities. Worldwide, it is the second most common cause of cancer-related deaths among women. Globally, in 2012, 530 new cases were diagnosed, leading to the death of 270,000 women. In Nigeria, over 14,000 new cases are diagnosed annually, and the second leading cause of cancer in female in Nigeria. The incidence of mortality are higher in developing countries due to late presentation of cases. The women present very late. Lack of screening in many parts of developing countries. The few available screening services are located in urban areas. There is lack of capacity to treat advanced cases. This is the pathways toward development of cervical cancer: exposure to HPV, latency, persistent infection to CIN1, 2, and 3, carcinoma in situ, and cervical cancer. The presenting symptoms of cervical cancer are abnormal vaginal bleeding. This bleeding may be postmenopausal bleeding, it may be postcoital bleeding, it may be intermenstrual bleeding. Also, foul-smelling vaginal discharge. In advanced cases, pain and fistula formation, which may be vesicovaginal fistula, abnormal communication between the epithelial surface of the vagina and the bladder, or rectovaginal fistula, abnormal communication between the epithelial surfaces of the vagina and the rectum. In VVF, the woman leaks urine uncontrollably. In RVF, rectovaginal fistula, she also passes feces to the vagina. The mode of spread of cervical cancer: the first is direct spread. It spreads to contiguous structures, surrounding structures, to vagina, lower down, to bladder, anteriorly, to the perimetrium by the sides, to the rectum posteriorly, and to the sacral ligament. It also spread through the lymphatics to obturator, internal iliac, external iliac, and common iliac. The least common mode of spread is through the blood. Hematogenous spread is not very common. The clinical management of cervical cancer involves, first, if a woman has any of those symptoms, that does not mean she has cervical cancer, because we have a lot of conditions that may make a woman to have bleeding. We need to confirm the management. We need to confirm the diagnosis, history taking, and special investigations. Cervical cancer is staged clinically. There are visualization to look at the spread, how fast it's going to spread. Then also need to take the woman to the theater to do clinical staging and cervical biopsy. No, the clinical staging doesn't necessarily has to be done in the theater. You can equally do it at the clinic. In the past, the WHO recommends what can be done in a third world country hospital. In 2018, there's a new figure staging for cervical cancer, which involves addition of imaging, and pathological findings have been added. Imaging such as ultrasound scanning, CAT scan, MRI, and PET scan can give information on the tumor size, lymph nodes involvement, and extent of spread. In the modified 2018 figure staging, like I said, it includes imaging and pathological studies. The use of CT CAT scan is limited in the evaluation of early cervical cancer. It cannot discriminate between cancer and normal soft tissue of the cervix. MRI is a more valuable modality for determining tumor size, degree of tumor invasion, vaginal extension, the extension to the body of the uterus, parameter extension, and lymph node status. Cystoscopy should be done if we suspect urinary bladder involvement. Chest X-ray is mandatory, intravenous urogram, and renal ultrasound scanning. During clinical staging, we check the extent of the spread of the cancer. What's the size of the cancer? Is the cancer limited to the cervix? Has it spread to the fornixes? Has it spread to the vagina? We also do a rectal examination. Is there any involvement of the rectum? We take biopsy from the suspected lesion. These biopsy specimens are sent for histopathological examination. And to take the biopsy, we commonly use the tisular cervical biopsy forceps. When we are taking the biopsy, we should ensure that the biopsy specimen incorporates both normal and abnormal area of the cervix, and that the tissue should be sufficient for the pathologist to make a diagnosis. We should also use very sharp forceps like the tisular. We should avoid crushing the cervix. When taking the biopsy from the suspected lesion, the instrument must be sharp. We should take care not to denude the epithelial covering, because it makes it very difficult to pathologists to identify the origin of the tissue. We should take sufficient amount of tissue. We should not crush the specimen. That's why you need to take a very sharp instrument. We should place the specimen on a piece of gauze with the stomach surface on the gauze. The specimen should be placed in formalin, usually 10% of our formalin, and we send the specimen to the laboratory with sufficient clinical information. The FIGO stage in 2018, in stage 1, the cancer is confined to the cervix. Stage 1 is further divided into 1A1 and 1A2. In 1A1, the depth of stromal incision is less than 3 mm deep, and lateral spread is more than 3, less than 5. In 1B1 is any lesion greater than 1A1 or less than 2 cm in greatest dimension. In 1B2, it is greater than 2 cm, less than 4 cm. In 1B3, more than 4 cm in the greatest dimension. In stage 2, the cancer has spread beyond the cervix. It involves the fornixes, the vagina, but the lower one-third of the vagina or the parameter wall are not involved. The upper two-thirds of the vagina is involved in stage 2A, but there is no parameter involvement. In 2A1, the total cancer is less than 4 cm in greatest dimension. In 1A2, it is more than 4 cm in greater dimension. In 2B, there is parameter involvement, but not to the pelvic side wall. In stage 3, the carcinoma is involved in the lower third of the vagina, but has extended to the pelvic side wall, or it is causing hydronephrosis or non-functioning kidney, and or involves the pelvic or parietic lymph nodes. In stage 3, the carcinoma is involved in the lower third of the vagina, but there is no extension to the pelvic side wall. Extension to the pelvic side wall or hydronephrosis or non-functioning kidney unless known to be due to another cause. In stage 3C, there is involvement of the pelvic or parietic lymph nodes, irrespective of tumor size or an extent. This can only be determined with etiological or pathological notations. In stage 3C1, there is pelvic lymph node metastasis. In stage 3C2, para-aortic or lymph node metastasis. In stage 4, the carcinoma has extended beyond the true pelvic or has involved biopsy proving the mucosa of the bladder. For you to say the cancer in stage 4, you must have biopsy result of involvement of the bladder or the rectum. The bullous edema, such as on the bladder, does not permit a case to be altered to stage 4. That is, a bullous edema of the bladder without histopathological confirmation does not permit a case to be allotted to stage 4. In stage 4A, it has spread to adjacent pelvic organs. In stage 4B, spread to the distant organs. Lymph node metastasis is the most important prognosis factor in cervical cancer. Risk of lymph node metastasis are related to the clinical stage. Stage 1B2 up to stage 2A, they have higher incidence of lymph node metastasis. Also, the bigger the tumor, the more the risk of lymph node metastasis. Tumors that are generally more than 2 centimeters are higher risk of lymph node metastasis. On pathological examination, lymphovascular space involvement is a significant risk of pelvic nodal metastasis in early stage cervical cancer. Performing simple hysterectomy, also known as extrafacial hysterectomy for invasive lesion, is an undertreatment. We should try as much as possible to avoid this. Don't do simple hysterectomy with the aim of sending the patient for the therapy later on. Because when you are doing radical hysterectomy, the lymph nodes must be removed. Sample and removed. Don't just do simple hysterectomy. We should also avoid combination of surgery and radiotherapy. So patients must be carefully selected. Either they undergo surgery alone or we send them for primary radiotherapy treatment. Because we could not do lymph node metastasis, does not mean we should operate on a patient on cervical cancer. Don't do simple hysterectomy. Try not to combine surgery and radiotherapy because this leads to higher incidence of complications in the patient. There was a review done by Yaranop et al. In 2014 of over 251 cases of advanced cervical cancer stage 1B to 2A. Lymph node involvement was detected in 11.6% of those patients. And that review by Togani discovered lymph node involvement in stage 1A2, 0. Stage 1B1, 17%. Stage 1B2, 22%. Stage 2A, 33%. Stage 2B, 63%. The advanced the stages, the more the risk of lymph node metastasis. Now, how do you manage cervical cancer? Like I said, stage 1. Stage 1 can only be diagnosed by microscopy because of the size. You only measure in millimeters. The management could be either cone biopsy or from a leaf specimen or from trachelectomy or from hysterectomy from other causes. Stage 1 cervical cancer, stage 1A rather, cervical cancer cannot be diagnosed by what? Clinically, except by microscopy. In stage 1A1, the lymph node metastasis is less than 0.5%. Treatment options are colonization or total abdominal hysterectomy. Stage 1A2, lymph node positivity is about 3.2%. Treatment options are, for stage 1A1, you can do colonization or TAH, in which you diagnose by microscopy. In stage 1A2, risk of lymph node metastasis is higher, 3.2%. Treatment options are total abdominal hysterectomy with laparoscopic lymph node dissection, or you do radical trachelectomy if fertility is of concern to the patient, that she desires of having more pregnancies. Large cone biopsy, if the margins are clear, may be therapeutic for stage 1A2. If the patient is not fit for surgery, then intracavitary brachytherapy and external beam radiation therapy can be administered. In stage 1B and 2A, both primary radiotherapy and radical surgery have the same cure rate. That is type 3 radical hysterectomy. The choice of treatment is dictated by the age of the patient, the desire to preserve ovarian function, and the woman also have comorbid conditions. That is stage 1A and 2A. Irrespective of the method of therapy, either radical hysterectomy, surgery, or radiotherapy, they have the same cure rates. But then what you choose depends on the age of the patient. If the man wants to preserve ovarian function, because primary radiotherapy will destroy the ovarian function, causing premature menopause. Also, if the man has comorbid conditions and could not withstand surgery, may elect to do primary radiotherapy strategy for her. Like I said, it is better not to combine both modalities of treatment because of increased side effects. Radical hysterectomy. The essential feature of radical hysterectomy is pelvic lymph node dissection from the common iliac to femoral ring. One needs to open the genital triangle to do this. You must, in the lymph node dissection, you must include both the external iliac, internal iliac, interiliac, up to the fossa. You will take dissection to enable parametrium to be included in the specimen. You must ligate the uterine artery from its branch from the internal iliac artery. You cord the sacral ligament must become from attachment from the sacral wall. At least 2 to 3 cm of vaginal wall must be incorporated into the specimen to be removed. After radical hysterectomy, the adjuvant therapy depends on so many factors. We have the risk factors, which is divided into high risk. The high risk factor for after radical hysterectomy, what we do afterward depends on the risk factor of the patient. If the specimen showed that the woman had lymph node metastasis, then she should go for chemoradiation. If she has positive surgical margin, then she should be given adjuvant therapy in terms of chemoradiation. That is combination of the therapy with chemotherapy. Or if more than half of the parameter is involved in the malignancy, then the woman should have a combination of radiation and chemotherapy. For intermediate risk factors, tumor size less than 4 cm, lymphovascular space invasion, and deep stomach invasion, the woman should have adjuvant radiation therapy. The use of neoadjuvant chemotherapy, that is, before definitive therapy, that woman is given chemotherapy. There is no data to suggest that the use of these drugs prolong survival of the patient. Those that use it say their aim is to downstage the tumor to inhibit the spread of micrometastasis, and that surgery may be more difficult. It's useful when cervical cancer is diagnosed in pregnancy. After radiotherapy or radical hysterectomy, how do we manage patients with cervical cancer? We should do cervical cytology every 3 months for 2 years, then every 6 months for the next 3 years. Though the interpretation of cytology after the therapy can be very challenging. To monitor this, we may consider the use of CT scan or use of other radiological studies like chest X-ray or PET scan. In conclusion, cervical cancer is the most common gynecological cancer in developed countries. Management involves confirmation of diagnosis through clinical staging and cervical biopsy. Definitive management depends on the clinical stage. Adequate follow-up is important after the primary therapy. This is to detect early recurrence. Thank you for listening.